Okay, so our next speaker that I'm very pleased and honored to introduce is Jay Hazelrigs. Jay is Vice President with the Actuarial Consulting Division of Optum. And most of you know that Optum is the sister company for United Healthcare, which pretty much covers most of us on campus here. Jay is located in Denver. He's the lead actuary for Optum's Accountable Care Solutions and Provider Risk Division. He has worked as a healthcare actuary for more than 20 years and consulted with multiple Fortune 500 companies throughout his career. His unique background includes consulting to government and commercial payers, providers, employers, and ACOs across a multitude of business and actuarial issues. He's an associate of the Society of Actuaries and a member of the American Academy of Actuaries. He graduated from Georgia State University with a Bachelor of Business Administration, concentration in actuarial science. The most distinguished thing he's done is Jay has co-authored Optum's response to the initial CMS ACO regulations, called The Implications of the CMS Proposed Regulations for ACOs, and he's a frequent speaker at actuarial and ACO events. So when I asked Joe, when I invited Jay to speak at this conference, he was very excited to talk about his actuarial experience and to combine it with the area of big data analytics. So Jay, welcome.
Thank you very much. Can everyone hear me okay? Super. I hope that's not my most distinguished thing I've done in my life is the co-authored of the paper. I want to first say I'm in awe of the speakers that have gone before, the department here. Really amazed by hearing what y'all have said already, and I think it's fantastic. So. And I wanted to thank everyone for letting me come down and give you a speech. Not a lot of people like to hear from an actuary, so we'll start there. Big healthcare data and actuary's view. So here's what I'm going to cover today. What's an actuary? We'll talk about big data and healthcare. I think you're going to hear a lot of the same themes we've already heard this morning already from the two previous speakers. And then I'm going to focus that on we're going to take that to the next step of real-world, I'll call it real-world data analytics. So what do we do now for our clients? So I consult with ACOs across the nation. Very fortunate to be working with these organizations. They range from pioneer ACOs to these other organizations called Medicare Shared Savings Program ACOs. If I'm talking about them, I'll usually say MSSP, so I'll go quickly over those. What those ACOs now are doing across the United States, that's another area where I'm in awe of the challenges they're taking on, of trying to disrupt how they deliver health care and really make a difference for the patients that they take care of. So, okay. So first wanted to start off with what's an actuary. Does anyone know what an actuary does first? Can't see. I see one hand, two. Wow, that's three. It's pretty good, actually. So here's I think the best way is to show you a picture to start off with. Picture's worth 1,000 words. Unfortunately, this really is what a lot of actuaries are, and these are the really smart actuaries. Hopefully I don't portray myself that way, but I'm one of the dumber ones, and those are the smart ones. So going to really what an actuary is, and we'll start off with the Society of Actuaries definition, which is our governing body. Business professional, analyzes risk, uses math, stats, and financial theory. I think that's a nice definition. An alternative definition is really predicts future events. For me, along with their associated costs. That's typically, I'm playing in the financial risk area. We're trying to estimate what the financial risk is for future events, usually using historical data. So you can take that as big data. I'd like to say it's big data. I don't think it's big data, but it's data. And then we look at what's happening in the current or future environment to try to estimate what's going to happen in the future. So a little cartoon to sort of put it in place. Always more expensive if you can get what's going to happen in the future. So big data in healthcare. I want to start off with, I wanted to share with y'all, Society of Actuaries did a survey last year, and they surveyed about 250 executives in the healthcare industry, mainly in the hospital delivery systems and in the insurance companies, health insurance companies. And with that, I'm going to share some insights that came out of that survey around big data. 66% of these executives said they have high expectations for the future potential of big data. 51%, 1 and 2, believe their companies are well prepared to take full advantage of data growth. I'm not sure if these numbers, as you start taking these in and digesting them, if this is what you would expect, are these too high or too low? Probably the first one, the 66%. I thought that was a little low, to be honest. So, but these are the numbers. If you take the 51%, and we're going to split that between hospitals and insurance companies. The insurance companies, about 2 out of 3 of them believe they are well prepared to take the full advantage of big data or health data as it grows. And only for the hospital sides, usually what the statistics said or the results said, only 1 out of 3 was prepared currently to take full advantage of the data growth. Lastly, as we turn to so how do you take advantage of the data growth? One of the questions was, do they have the current staff that has the required analytic skill sets for that? 3 out of 10 said they do not. So quite a big gap there with all the growth and explosion of the big data. How are we going to take it in? How are we going to make sense of it? How are we going to inform, create insights, and drive business decisions? Peeling that onion back a little bit more, probably not surprising, the insurance companies, only 1 out of 4 thought they didn't have the correct staff. For the hospitals, more like a little more than north of 1 out of 3. So, when asked what kind of what was the current value of big data, the executives broke it up into these 4: don't know, not sure, provides no current benefit, provides some benefit but not much, provides substantial benefit. If you start at the sort of the 12 o'clock position, 6% don't even know. That was a little surprising to me, seeing that number. 45% says it provides substantial benefit today. And then the key one here is almost half provides little or no benefit today. That's I guess it's a little disappointing to think about, but lots of opportunity there. I think it's the same themes we've already heard. I'll touch a little bit more on this staff. How are we going to find the right people? We don't have the executives are saying, I don't have the right people now. I got to find the right people. So all the students here, this is great news for y'all if you want to be in healthcare. So as these companies are looking to find the right staff, there's only, you can see the bottom, 17% they say they have no issues finding the right staff. And then really over 80% of the respondents have indicated they do have challenges. Now, to continue that, almost 80% plan to hire skilled staff in this area over the next 3 years. So good news there. So I want to take a step back now and talk about the big data definition. And I'm going to be honest, when I was asked to have this to come down here, my first question, I think, to Dr. Ram was, I don't know what big data is, to be honest with you. I use a lot of data. My company uses a lot of data, but what really is that? We've seen the 4 V's, I guess, already: volume, velocity, veracity, and variety, so I won't go through that. But I think the key is, how do we take that data, big data, scale it, do analysis on it, and really create those enhanced insights for decision-making processes. So this is generic, obviously, generic form of the big data. Gartner model modified. So I thought I'd pause here. We've talked about the 4 V's. But really, from the Gartner's original model, or the original model, there's only 3 V's. So which of these do not? Does anyone know which of these that does not belong? Yes. Number 2. That's right. So that's probably basic for everyone here, now that I've been involved, now that I've seen this audience. So I wanted to shift and take the sort of that big data context and move it to healthcare. That's what we're trying to look at on this slide. We still have the 3 V's, velocity, volume, and variety. We've got a different sort of output context coming out of complexity. I believe Dr. Rem said something earlier, or Paulo said something about the complexity of the data in healthcare, or overall, but in healthcare, I find it very complex, and that's one of our challenges, is how do you take these complex data sets and bring it together to make it a better data set to create those insights. So within the data, we've sort of listed out here, what do we, sort of in healthcare, what are the main suspects of data elements here? Tests and treatments, those are what I would say, that's the old tried and true kind of data elements. That's, I go to a doctor, I see him, he turns around, writes down 99213 office visit, turns around and sends in a bill to the hospital, to the health insurance company, and he gets paid that way. There's his $80 that comes back to him. That's the test and treatments kind of stuff, and that's standardized. It's been around for a long time. And quite frankly, for actuaries, that's really, we have my history of working with healthcare companies. That's where I've played in. That's the space that I've had data, good data, the veracity of the types of it, knowing that it's good data because it has the financial pieces of it. Clinical data, obviously a big push right now with how do we marry the clinical data with the claims data. And although that seems pretty simple, it is quite of an adventure to try to get that to sort of to mesh. But clinical data, that's what the notes that a physician might write in his or her EMR after an office visit. Health risk assessment, socioeconomic data, vital signs, medication orders, admissions, discharges, and transfers. This is all kind of the data that we're trying to bring together to help us gain more insights. At the bottom here, we've got more of the future data sets, and I think a lot of people would say, well, I think some of these are here already, and I agree they are here, but how do we really use them? And I think at the bottom, the genomic, that's, I think I saw that on the previous, on one of the topics on the previous slide, so I know everyone's trying to get there. For me as an actuary trying to predict the financial futures, I would love to have that data. It's all kinds of questions with ethicals, the ethics around getting that data. So, but I know I could probably be, if I knew someone had a disposition for a certain type of disease, sure would make my life a lot easier to guess how much they're going to cost. I guess guess is we shouldn't use that word for actuaries. Estimate how much their costs are going to be in the next 2 to 3 years. So, hopefully y'all can see this. Thank goodness it's a big screen here. Going from the generic healthcare big data model to more of how is Optum approaching this? I just wanted to share this with you some. What you're going to see is the different data types sort of going across the middle there in the orange in the various boxes. Those were the information that was sort of on the previous page. What we've also added here is the more granular information. So, for example, take the third column over, physicians and facility claims data. That was that top one, sort of the treatments on the previous page. What kind of data elements do we want from that though? As you can see, we've highlighted CPT-4 codes, diagnosis codes, could be ICD-9 diagnosis, ICD-9 procedures, and we want to take that data in. From an actuary, that's where I sort of play, but we're expanding our view of how much data can we take in, make sense of, and that's really sort of everything above the Optum real world analytics warehouse piece there. And I would say that's more of what's happened in the past. And the EMR and the EHR data and the clinical data, that's sort of what's happening right this second. And you should not take this as saying I don't agree with Dr. Chowdhury as we need to do a lot more, but this is sort of where current state is. I think for a lot of technology companies out there. So obviously we're trying to bring all this data together to gain those insights. One of the questions you might ask is, well, where does all this data come from? Isn't this already out there? Isn't it easy to get? And unfortunately, it's not. And that's one of the biggest challenges, is that when you look across the various stakeholders that have the data, they may not want to share the data. They may not be able to share the data because of privacy issues. So we had this conundrum of, I think we all agree data could help us. It's not the end-all be-all, but it could really help us accelerate what needs to be accelerated in the healthcare area with learnings and patient outcomes. But how do you get people together? How do you share this data? This is a very short list, and this list would be ginormous if I tried to capture everyone that's sharing data now. What's been very what I've seen is very optimistic is the various stakeholders out in the country are really trying to come together to figure out how do we create bigger, better data assets. I'll highlight a couple of things here. You'll see the life sciences companies looking partnering with data and analytics on the top left, as well with payers and PBMs. A few years ago, this would have been unheard of. They would never have done that. They were more competitors and would not want to share data, but you're seeing these barriers get broken down now in the industry. Even so much that that I know of a large metropolitan area where the hospitals, and these are competitors, they're sharing ADT feeds and other types of information because they've realized if we don't start sharing this data with our competitors, it's really going to hurt us in the long run too. I think that's still being figured out. I think it's real. It makes a lot of the hospital executives very nervous, but I think it's good to see those collaborations start to happen. So I wanted to get in some real-world analytics, talk about sort of what we do on a day-to-day basis with our clients. The first thing I wanted I thought I'd share it now, the Actuary's most well-kept secret. Never shared this with anyone. So, and most actuaries would be upset if I did, but thought I'd go ahead for this audience. It's academic purposes, right? So this is what actuaries, this is our biggest secret. So we have our black boxes. People like to say that. My clients think I have this, that's for sure sometimes. So, but we really don't have black boxes. We really do a lot of analysis. And I'm going to just jump in now. And I got to lay a little bit of a framework of when we work with our clients, what we're really trying to do. For me, the way I'm coming at it, financial risk, I break that down into really two sets. How do I find, this is really in the context of an ACO, how do we risk stratify? That's really the question. And we're going to risk stratify the patients, who are high-risk patients, and who are high-risk providers. I always have to say, I know there's a lot of providers around. High-risk providers doesn't necessarily mean bad providers, that they may have a panel that has high-risk patients in them. It may mean there's some improvement in how they deliver medicine, so we'll get to that. But usually that's where the construct I start off of trying to think about how can I find in the data high-risk providers and high-risk members. And that's because we all have limited resources, and what can we do for them now? And oh, by the way, what's the action item? I've heard that a million times. There's people in this audience that have actually said that to me. So I can equate to that real well. So I usually say, what's the so what, though? It's great to do data analysis, and you can find some really interesting things, but so what? If you can't answer the so what, then you haven't done your job. So we're going to do a little drill down analysis, show you sort of how we look at the data. We're going to start off with looking at major practice category and episode treatment groupers. Probably a little background when I say episode treatment groupers. I'm not sure if people know what that means, but basically the way we look at data is we look at patient data. We can put that, use our algorithms to say this set of data over this period of time is a group. It should be grouped together for specific treatment. And let's make sure we only have services that fall within that group are tied to this ETG. For example, if I had a knee surgery, knee replacement, let's say that takes 6 months from being diagnosed to my PT being done. And then within that 6 months, I also had, I call it the flu, these algorithms for ETGs. What we're going to do is look at that, and we're going to say the services only applicable to the knee are going to be grouped over here, and the services applicable for the flu are going to be grouped over here. Those are going to be 2 different episodes. And what we're going to do is say a provider managed. We're going to figure out how to assign that episode to a provider, because there's a winning provider is what we would say, but who is responsible for the care of that patient for that episode. So that's the background for ETGs or groupers. So the first thing, though, we do is at a high level look at the major practice categories. Hopefully you can, yep. And as you look across this, cardiology, endocrinology, orthopedics, you can see the various body types going across here, or major practice categories. And what we're measuring here is what's the total amount of spend associated with those. So for the episodes that roll up into cardiology, as you can see, that's the predominant spend or cost for taking care of patients within this population. And so that in itself is a so what. Okay, that's nice to know, but so what? So what we do is then we'll drill through that. We'll say, okay, let's break that one down and see what's underneath, what's under the hood of that, of cardiology. And now we're at the ETG family levels. So as you go across here, now we've got different categories. If you probably can't read that, I'm going to read left to right: ischemic heart disease, hypertension, congestive heart failure. And I'm not going to read the other ones, because they sort of, as actuaries try to look at, where do I start looking to find these high-risk patients or high-risk providers or cost efficiencies? Well, you got to go where the data takes you. You got to go where the costs are, and that's where the costs are right now. So when we look at this, the question is, well, okay, we're still at a so what. I've sort of narrowed it down, but so what? And so the next one, what we want to do is, I've just picked one, congestive heart failure, to try to get to that so what, to look at what we're doing here. So this is the sort of the next drill through. And what you're seeing more on the bottom here is the visualization of the results of what we've done here. And we've taken, for this one ETG congestive heart failure, we've looked at all the ETGs by patient, rolled them up to a provider that managed those ETGs. We actually did it by practice. So physicians are part of a practice. We've rolled them up to a practice level. And this is all made up data, by the way, so don't try to look at if these are good providers or not. And what we want to do is measure them then. This happens to be a cost efficiency measurement. You can do this on quality, but we're looking at cost efficiency, and we're looking at we call it actual to expected ratios, an A to E kind of study. When you're looking here, we've got all the circles down here at the bottom represent practices. The green, just to real quickly orient, is less than 1.0. The red is greater than 1.0, and then you see the 1.0 average there. As you go up the axis, that shows you the number of episodes these practices managed, and then the horizontal axis is the actual to expected ratio. One other piece of that visualization is the size of the bubble represents, the context of here is cost savings. So anything that are potentially cost savings. Anything to the right of the 1.0, this is I think I've got my thing. It should be greater than 1.0 indicates less cost-efficient providers. Anything that's less than 1.0 indicates more cost-efficient providers, and the 1.0 is average. So that's your actual to expected ratios. So here, if you're using this tool, you would actually be able to highlight, you could go to the circles, hover over that, it would pull up a call-out menu that would say, this is this practice, this is the number of episodes they've done, this is the actual expected ratio, and here's the potential cost savings if they were at a 1.0. So now this is all risk-adjusted, severity-adjusted when we do these analyses. Let me first say, I should also say, is they're not perfect. They will never be perfect. directionally they are very good, very, very well, but not perfect. Now, what do you do? So what? What's the next step from this? Well, finding the ones that are more outliers, you would do a little bit more drill downs to understand why did they sort of end up being on the outlier list, and what can we do about them? So there's still more drill throughs that have to be done with that, but I just wanted to show you sort of the way we look at that. And on the top here is actually the numbers. If you're the actuary, the actuary's eyes go to the numbers. I think a lot of other folks, we want to look at the visualization of it. So the next slide here is, we talked about emergency room visits. How do we, that was an earlier slide. And I think we have the same themes of where do we want to focus to try to find these cost efficiencies, and potentially avoidable ER visits is absolutely an area that we work with our clients on. So on this dashboard that has the underlying data, we're gonna highlight a couple of things here. Back to high-risk members, high-risk providers. I'm trying to find out who they are. With the high-risk physician practices, again, this doesn't mean the physician's practicing poor medicine. It might be a poor panel. But what we can see here is the top one, there's CRHS Denver West. The way you would read that is they've had the highest number of potentially avoidable ER visits, and we've done that. We've done an algorithm in the back to identify those. You can see there are almost 2,000 of those in their practice, and their rate of potentially avoidable ER is 29%. So we've already risk stratified those practices based on this one metric. So perhaps the next question is digging more into why is this happening? Do you not have sufficient office hours for folks that you're serving to be able to come maybe at 6 o'clock or 7 o'clock or something else at night? So that's why it's happening. It's not the answer still, but it's got us very pointed on where should we start asking those questions. Off to the right, high-risk members. This table here looks at, let me explain it. So the size of the bubble, each bubble represents a patient or a member. The size of the bubble represents how many ER visits they've had. So relative, you can easily tell relative to all the other patients which ones are going to the ER the most. And then the color of the bubble tells us, are they potentially, are they really needed ER visits? Or potentially avoidable ER visits. The more red they are, the more they fall in the latter category of potentially avoidable. So if this was the tool up, you would hover over that. We'd go to that. Obviously, your eyes get taken over to the large bubble. You'd hover over it. What would pop up? It'd tell you the patient's name. It would tell you the PCP that they're associated with. They tell you how many ER visits they had. In this data set, that person was like 172. And so what is, what could you do with that? Maybe you call up the PCP that they are supposedly this patient's assigned to, and tell them, let's say it's Jay Hazelrigs, hey, just letting you know, Jay Hazelrigs is either at the emergency room either today or tomorrow. So what can we do about it now? So the last piece here is more of, if you want to drill down and to understand what are those services, those ER visits, the diagnosis, or the ETG families? What's driving those potentially avoidable? So it's great that we know people. It's great that we know the doctors, but what's the symptoms of it? I mean, what's the diagnosis? So there's a way that we're able here to drill down through that. So I just got a couple more slides here, I think, for samples. This was talked about her benchmarking earlier, and we absolutely use benchmarking on today's analysis. Folks want to benchmark all the time to say, well, I've got to have a target. Let's do a benchmarking analysis, and then I know where I can start focusing my resources to hopefully to meet the objectives of my company. This happens to be a percent of spend by body system. We're benchmarking a health plan. We looked at all of Pennsylvania, national data, Mid-Atlantic division of this health plan, and then for this specific health plan in this state. And what we see here was that orthopedic rheumatology and neoplasm, they actually had lower than the benchmarks. Their lower spend as a percentage of spend was lower than the benchmarks. And then endocrinology, neurology, you can see those, the ones that were higher. We identified those as having higher spend as a percent than what the other benchmarks are. So what? So the question here, I think the answer to the so what is, let's say this health plan had money to spend in care management. I'm going to create a new care management, or I want to hire nurses. I want to do something. I've got to invest in my business. This helps them point at what is the area that I need to invest in my business, or what kind of training do I need to do with my current care managers, because I have a higher preponderance of folks in the endocrinology, or probably the diabetes. So. Pharmacy claims. I want to touch on this, and this is really where we're starting to marry, or where you get to start marrying the EMR data, the clinical data, and what the claims administrative data is. So we're able to see, what did the doctor think should be done? Maybe what did they order? What did they write? What was the prescription written? And then when we go back and look at the claims data, what actually happened? And is there, what the doctor thinks is happening? Is it happening? If it's not, what's the consequences of that? And we can quantify that and understand, is this an issue that needs to have more resources focused on it, or is this okay? So this happens to be for Lipitor written prescriptions and dispensed prescriptions. WRX is written prescriptions for distribution of Lipitor. As you look at this, we looked at Lipitor in the next 90 days. And what we saw was 73% of the Lipitor prescriptions were filled as written. We saw 5% of them get moved, switched to another statin, and then 22% were not filled within 90 days. For all physicians, I'm sure, ding, 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 this is a problem. What do we do about it? We also looked at, well, that's great to know they weren't filled, but let's look at the distribution by days too. So when were they filled? And we saw same day of 42%. And then we broke it down by 1 to 15, 16 to 45. And you can see those there. You still have the 22% no fill. So I got 5 minutes, so I better wrap up, which is good. I'm right here. So healthcare is complicated. Wow, I'm so glad I'm on the same theme as everyone else, to be honest. So healthcare is complicated. Healthcare data is complicated. That's a fact. So we just got to get better at it. I'm just going to, this is no big aha there. For really where's the market going for staff and resources and talent? Stakeholders are bullish on the big data, but we still need more alignment with among the stakeholders. They're aligning slowly, but accelerating data. One of the issues is, I touched on this data privacy. The Affordable Care Act really has removed some barriers. As you look as employment, though, too, as demand exists for the healthcare big data skill set. So world is your oyster, I guess, for the students. So thanks a lot.
Jay, I have a question for you.
Oh,
Pat
no,
Levins,
you're
I always
not
have a
allowed.
question. Would you talk a little bit about the waivers that were relaxed, or do you, when the final regulations came out on the Accountable Care Organization from CMS? Because that certainly is helping to remove some of those barriers, and that was a difficult process that Dr. Berwick was able to get through when he was at CMS.
Yeah, CMS, very specific question to CMS and ACOs. There's basically what Powell's talking about is how are the rules set up before to share data, to be integrated systems, to get around the Stark laws. And so CMS, for the Affordable Care Act, did relax some of those waivers. And they continue to look at, how do we relax waivers? How do we add more waivers? Unfortunately, what we're seeing is the MSSP ACOs and Pioneer ACOs, they sort of run on different programs at the higher levels. Pioneers are afforded more waivers now. I wish the MSSPs were afforded the same. So I think those rules, unfortunately, we live in a society where there's rules out there that were done for good reasons, but it does create barriers for us to really accelerate some of these learnings and collaborations. But I think CMS is doing a better job with that. So.
You spoke a little bit about healthcare organizations starting to share data more extensively. I wonder if you could spend a little bit more on what are some of the key drivers behind that. You mentioned people realizing they needed to do it to compete. How can that process be enhanced, accelerated?
Key drivers, I think we all realize, many of the stakeholders, that if we don't do something different, if we don't disrupt, we've pretty high probability of being a single payer system here. So I think that's one piece of it. I think that's what's got some people off the fence. Two, I mean, there's the capitalistic society of us that people just want to make money, and let's make it better for the society. If we can make better things that purchasers need, well, that's good. And I want to innovate and make money for that. I think speaking a little bit more about big data, I'll touch on what could really help is if CMS started actually sharing their data, made that more publicly available. That would be a huge step forward, and I think it would really help accelerate some of these learnings and innovation. So right now, the way I look at it, there's the collaboration going on, but it's still fragmented. So who's going to step up to really bring that together? All the different fragmentation that's happening with the collaboration, and once we can solve for that, I think it does create that sort of stepping on the pedal, making it faster. So.
I just wanted to thank you and all the other guest speakers for your interesting and engaging lecture so far. But although I do have a question, so you're not off the hook that easily. In regards to sharing data, how do you foresee privacy or ensuring privacy or HIPAA training enforcement working alongside big data in healthcare?
That's an enormous issue. It's front and center. There's just privacy. Whenever you're starting to look at data, share data, you can't get around that. You have to work around protecting the privacy. That's the laws and regulations that we have to work in right now. Do I agree with it? I don't think we want to debate that, but that is, as you're looking, and maybe these are your fields that you want to work in or you are working in, the privacy is a big challenge. It is costly. It does hinder. It definitely does hinder that acceleration of really figuring out how to innovate.
So we're starting to see a lot of insurance companies laying out physician plans for care, specifically in oncology, as far as routes of care for certain line treatments. And I'm sure a lot of it's based on data such as what you guys are doing. Can you discuss what companies, actuaries, insurance companies are doing to discuss with physicians and practices the data that you guys have behind doing these setups on lines of care, courses of care to help reduce healthcare costs in general? Yeah,
and I'm sorry, could you repeat the first part of your question? I didn't hear you very well.
So we're seeing a lot of insurance companies setting the lines of care that specifically like in oncology, if you're diagnosed with a specific cancer, you're going to have first line treatment of this drug versus this drug, second line is going to go over here. A lot of that is being based on data from actuaries and doing a lot of these large claims and outcomes data. Mm-hmm. So specifically, what are the insurance companies and the actuaries doing to discuss this with physicians and practices? Because obviously they're very concerned that we're replacing the physician with robots doing data.
Sure. So I think there might be a misnomer that's within your question. I'll say I don't think actuaries dictate the process of how care is delivered. Actuaries will quantify the cost of different care pathways, which I think that's what was you were first saying. So absolutely, an insurance company or an ACO might say, we think this is the best way to provide care with these kinds of programs, with these kinds of people, and do we think that's a financially viable solution? That would be the question to the actuary, and we could do that in numbers. From the standpoint of, is this the correct care pathway? Are we following evidence-based medicine guidelines? That is not the actuary. So I do think I don't think necessarily insurance companies are, and I really can't speak for them. Let me guess a little bit, though. I do think they do pay attention to evidence-based medicine. I do think they are drawn to care pathways. I think that's an area, care pathways is an enormous opportunity for big data to really discover what are the most appropriate care pathways. That will take a huge amount of data to understand that. People are doing it now for care pathways. Are they the right care pathways? I don't know yet. I don't know if I answered your question at all, but I wanted to give you a little more different view of that. So, but I don't think insurance companies aren't, they're not saying do something without following these other guidelines. That's my understanding. So, but I could be wrong.
I think everybody's ready for lunch. So
Super. All right. Thank you.